Good afternoon, Commissioners. We are now live.
Good afternoon and welcome to the October meeting of the Health Policy Commission. Welcome to my fellow commissioners and also to all those who are participating through the live stream. Let me start by reviewing our agenda. We're going to begin with the Executive Director's report and then move to the market oversight section of the agenda, where our briefing and discussion is going to focus on the Steward-related sales. First, we're going to review and discuss the final report on the HPC's review of the sales of Steward's 6 Massachusetts hospitals. Those sales were finalized on Monday, September 30th. Then staff will provide findings in the review of the acquisition of the Steward Physician Group by Rural Health Group, which is underway now. We'll then hear from Executive Director David Seltz, who's going to review the final 2024 healthcare cost trends report and the policy recommendations for this year's report. We'll then ask the board to vote to publicly release the report. We'll also have the opportunity to review the next video within the HPC short series. This video focuses on severe maternal morbidity, building off the findings from the HPC's research exploring inequities in the rate of severe maternal morbidity among birthing people in Massachusetts. We'll then review and discuss the proposed awardees selected from an applicant pool for the HPC's Heart BP investment program. This is a program using remote technology to monitor hypertensive disorders for birthing people. And we'll take up a vote to approve the selection of the awardees. So first, before we move to the rest of the agenda, we need to dispense with the minutes from our last board meeting on September 19th. And I'll turn it over to Colleen Elstermeyer to take the vote.
Thank you, Madam Chair. Good afternoon, everyone. Do I have a motion on the minutes?
So moved.
And a second, please.
Second.
Okay, great. And by roll call vote, starting with you, Chair DeVoe.
Approved.
Vice Chair Cohen.
Approved.
Commissioner Blakeney.
Approved.
Commissioner Cutler.
I missed the last meeting, so I need to abstain.
Excellent, thank you. Commissioner Foley.
Aye.
Commissioner Master Giovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Kwasnick.
Aye.
And Secretary Walsh.
I need to abstain. Thanks.
Thank you. Okay.
Thank you. And now we'll turn to the Executive Director's report.
Great. Thank you so much, Madam Chair, and thank you to everyone for joining us today. I'm going to quickly move through the Executive Director's report because, as the Chair said, we have a really big agenda today. So on the first slide, I wanted to let our commissioners and everyone know, following up from our September board meeting, we announced the new HPC Behavioral Health Workforce Center, which we've launched in partnership with the Executive Office of Health and Human Services. I'm pleased to share information on the center's new advisory group, which will support the center's research agenda and the development of policy recommendations and all of the work moving forward. So we are currently requesting nominations for advisory group members. And this week, a notice of opportunity was posted to Combis and posted to the HPC's website. So we're looking to convene providers, patient representatives, industry experts, policymakers, community advocates, all of these folks to provide BH workforce expertise and insight to the center's work. So to be considered, you must submit a completed nomination form for yourself or on behalf of a nominee via email by Friday, November 15th. That's the deadline, so a little over a month. Tons more information on the notice, nominee criteria, selection process, submission instructions, everything's on our website. It's it's masshpc.gov/BH-workforce. So you can find everything there. Really encourage you to apply if you're interested in serving. And we're planning to roll out decisions in early December. On the next slide, I wanted to give a notice about our upcoming cost trends hearing. The Health Policy Commission's 2024 healthcare cost trends hearing, scheduled for Tuesday, November 14th, 9 o'clock in the morning, Suffolk University Law School in Boston, will also be live streamed on the HPC's website. The theme of the hearing this year, From Crisis to Stability, the path to a more affordable, accessible, and equitable healthcare system. This year's hearing, as in the title, particular focus on the dissolution of Steward healthcare, the toll it's had on communities, on patients, provider orgs, healthcare workers across this region. So, as always, we're convening healthcare leaders from across the state, diverse perspectives on this recent crisis, and also insights into the necessary policy solutions to achieve our affordability goals, our access goals, our equity goals as a Commonwealth together. So we're opening this to a limited number of in-person attendees. If you would like to attend, please visit the link on this slide to register and get registered early. We've already got some really important witnesses confirmed, and we'll be sharing more information on that very soon via our website, masshpc.gov. And that's it on the hearing. Okay, back to you, Madam Chair.
Thanks so much. And I'd like to turn it over to Executive Director Seltz to introduce the topics in the market oversight.
Thank you, Madam Chair. Good afternoon, Commissioners. Good afternoon to the public. Thank you for being here today. We have, as has already been said multiple times, a very full agenda, so I will keep my introductory remarks to a minimum here. We're going to start at the market oversight section here today, sharing our findings of the Steward Hospital transaction reviews. As has been noted, these hospital transaction reviews closed on September 27th, and the hospital sales were completed on September 30th, and the new operators took over on October 1st. As you'll notice, as we walk through the timeline, the HPC received material change notices for these transactions in the first 2 weeks of September. And you might be surprised to see the level and depth of work that we did given that short time period between the first 2 weeks of September and September 27th. But what I can tell you is the HPC was hard at work analyzing these transactions for many months prior to receiving the material change notices. We were aware, of course, of who the acquiring entities were going to be through the bankruptcy court process, and so have been preparing our work and our analyses prior to receiving those notices. That head start allowed us to be able to move very expeditiously through that review process once we did receive the material change notices. In addition, many of these parties to these transactions are known to the HPC and have been parties to previous transactions. This too allowed us to be able to work very expeditiously in our reviews. So while we did move quickly to close review of these transactions, as you'll see, that in no way impeded our ability to do a very thorough and in-depth review of all of these hospital transactions. And so for today, we wanted to share with you and with the public and with the healthcare market the findings from those in-depth reviews that led us to the conclusion not to proceed with a cost and market impact review for each of these transactions. So with that as an introduction, I'm very happy to turn it over to Megan Wolf, who's going to be walking through each of these transactions. There's a lot of content here, so please raise your hand, interrupt, ask questions. And I know that she'll be pausing after each of the transactions for questions and discussion. Megan?
Thank you, David. The bankruptcy and dissolution of Steward Healthcare, the third largest healthcare system in Massachusetts, has resulted in an unprecedented disruption to the Massachusetts healthcare system, which has taken a significant toll on communities, patients, and healthcare workers throughout Massachusetts. The HPC, through its unique role and expertise as a healthcare market monitor, has had the opportunity to support the state in efforts to mitigate these impacts. We also had the opportunity to closely review the proposals to transfer 5 Steward hospitals to new operators to ensure that the interests of Massachusetts communities, patients, healthcare workers, and others are being protected. We are going to walk through our key findings on each of these reviews, but I did want to say up top that overall, the HPC found that while the proposed hospital transactions represent significant changes to the Massachusetts healthcare market, the HPC's review did not uncover evidence that these transactions are likely to significantly increase healthcare spending or negatively impact market functioning. To the contrary, HPC finds that the proposed acquisitions offer a critically important opportunity to maintain access to services for the patients of these institutions, while offering real opportunities to improve quality and stabilize the healthcare market. Recognizing the urgency and necessity of maintaining access to these important providers, the HPC closed its reviews of the acquisitions of these 5 hospitals on September 27th, so that the hospitals could transfer to new operators by October 1st. Obviously, commissioners, you've received a lot of information from us about these reviews in the lead up to that decision, but we wanted to take the opportunity to walk through our findings in depth in today's public meeting as well. If you could turn to the map next. Thank you. As a reminder, this map, which we showed in September, displays the location of the Steward hospitals involved in the current sales in blue and the hospitals of each acquirer. North of Boston in the squares, you can see the 2 Holy Family campuses and Lawrence General Hospital, the proposed acquirer of those locations. Holy Family's Methuen campus is just 2 miles from Lawrence General, and Holy Family's Haverhill campus is about 10 miles away. In Boston and just south of Boston in the triangles, you can see St. Elizabeth's, Good Samaritan, and Boston Medical Center. And in southeastern Massachusetts in the circles, you can see Morton and St. Anne's, located to the east of Lifespan's 3 acute care hospitals across the border in Rhode Island Hospital, Miriam Hospital, and Newport Hospital. Next slide, please. We have included an updated timeline here as a reminder, beginning with Steward filing for bankruptcy in May. The HPC received, as David said, material change notice filings for the sale of Stewardship Health, Steward's employed and contracting network physician group, to Rural Healthcare Group through its affiliated Brady Health buyer on August 15th, and August 22nd, the bankruptcy court approved this sale. On August 31st, 2 of Steward's hospitals, Kearney and Neshoba Valley, closed. On September 4th, the court approved the sale of the other 5 Steward hospitals in Massachusetts to 3 other buyers: St. Anne's and Morton to Lifespan, St. Elizabeth's and Good Samaritan to Boston Medical Center, and the 2 campuses of Holy Family to Lawrence General. And as David said, we received MCN filings for these 5 hospital acquisitions in the first 2 weeks of September. And we received an MCN filing related to the employment of physicians affiliated with St. Elizabeth's and Good Samaritan by BMC on September 16th. We completed our reviews of the hospital acquisitions on September 27th, as we've previously noted, and we understand the hospitals transferred to their new owners by October 1st. We are also in the final stages of our preliminary review of the acquisition of Stewardship Health by Rural Healthcare Group, which we will discuss later today. But first, I will walk through our findings of the hospital acquisitions. Next slide, please. I will begin with the acquisition of St. Anne's and Morton by Lifespan, the largest healthcare system in Rhode Island. We provided an overview of the transaction as part of our last meeting, but as a reminder, the purchase price was $175 million, much of which was being used to purchase the physical properties. The transaction also included employment of some of the physicians affiliated with St. Anne's and Morton. The parties stated that the hospitals would be operated in substantially the same way following the acquisition. Next slide, please. This slide summarizes our key findings from analyses of the potential impacts of the transaction, which I'm going to walk through in detail in the coming slides. Next slide, please. First, to orient you to who these parties are. St. Anne's Hospital in Fall River has high public payer mix, relatively high commercial prices, and generally strong financial performance. Next slide, please. Morton Hospital in Taunton also has high public payer mix, is moderately priced, and has had some financial difficulties in the last 5 years. On the next slide, Lifespan is the largest provider system in Rhode Island, with 3 general acute care hospitals, a behavioral health hospital, and a number of physician practices. It has had strong financial performance in recent years. On the next slide, you can see in our reviews, we engaged in our normal review of changes in market shares and market concentration as a result of the transaction. But I do want to acknowledge up top that under federal antitrust guidelines, there is an acknowledgement that when an organization is a so-called failing firm, such as an organization going through bankruptcy, like the hospitals here, transactions that may have otherwise been viewed as anti-competitive may be still permitted to proceed. When we analyzed market shares and market concentration for the parties here, we did find that Lifespan's acquisition of St. Anne's and Morton would increase market concentration in St. Anne's primary service area. However, there are a few different mitigating factors, even beyond the fact that these hospitals were going through bankruptcy. First, the service area in which we see the increased market concentration includes parts of both Massachusetts and Rhode Island, which do not have many payers and insurance products in common. So the increase in market concentration does not necessarily translate into increased bargaining leverage. Additionally, looking at the hospital acquisitions as a whole, market concentration statewide in Massachusetts is expected to remain unchanged. These dynamics mitigate the likelihood that the transaction could lead to increased prices. Additionally, the transaction may lead to shifts in tertiary and quaternary care from Boston AMCs to the generally lower-priced Rhode Island Hospital and its associated pediatric division, Hasbro Children's Hospital, which would likely decrease spending for Massachusetts patients. On the next slide, we also note when we compare St. Anne's and Morton's relative prices compared to other community hospitals with a presence in their service areas, St. Anne's is already higher priced than its local comparator, and Morton is moderately priced. Neither are starting, however, at a low price point that is likely to increase dramatically. On the next slide, while the party's quality performance was generally comparable, we found that Lifespan performed better than Morton on measures of patient experience and better than St. Anne's on measures of timely and effective care. This transaction has the opportunity for quality improvement at Morton and St. Anne's in these areas in particular. On the next slide, we examined the party's payer mix. St. Anne's and Morton provide care primarily to Medicare patients at 66% and 63% of their inpatient stays respectively, more than the average mix in their service areas. It will be important to maintain access for these patients. On the next slide, as I also mentioned in September, Southeastern Massachusetts has had a number of healthcare disruptions in recent years, including hospital and physician group closures, in addition to the pandemic. We found that this transaction would help prevent further disruption in the region by ensuring continuity of care at St. Anne's and Morton. Additionally, and further mitigating concerns, Lifespan made specific commitments to the Commonwealth in order to receive supplemental funding for Morton, including operating Morton as an acute care hospital at least through fiscal year 27 and continuing to participate in Mass Health. These are in addition to conditions imposed by the Determination of Need program, which are discussed on the next slide. Lifespan has also stated that it has no current plans to change services at either Morton or St. Anne's. On the next slide, each of the Steward Hospital transactions also submitted an emergency determination of need application with the Massachusetts Department of Public Health. In approving these applications, the DON program imposed identical conditions for each hospital, which you see summarized here, specifically related to facility improvements, operations, service changes, and patient access, including a requirement to make good faith efforts to participate in the same insurance plans post-closing, and that all providers at the hospitals participate in Mass Health within 2 years. Thus, while Lifespan's commitments to the Commonwealth to receive supplemental funding were only for Morton, it is subject to the DON conditions for both Morton and St. Anne's. Next slide, please. Based on these findings, that the acquisition likely will not increase bargaining leverage substantially, that there is a potential to reduce spending for Massachusetts patients by shifting some tertiary and quaternary care from Boston AMC's and Boston Children's Hospital to Lifespan's lower-priced AMC, and that the transaction has the potential to improve quality at Morton and St. Anne's. And most importantly, the transaction maintains access to these two hospitals, which are important providers of behavioral health, chronic disease care, and emergency services. Based on all of those findings, and in light of the DON conditions and commitments tied to supplemental funding, the HPC chose not to conduct a cost of market impact review of these acquisitions. The HPC completed its review on September 27th, and the transaction was completed by October 1st. Going forward, the HPC plans to monitor cost, quality, and access data for the parties and review materials submitted to the DON program. I will pause here before moving on to the next transaction in case there are any questions. Hearing none, we can move on.
I do have a quick question about the agreement that was made with Lifespan regarding Morton Hospital. So you mentioned that that they agreed to operate Morton as an acute care hospital through the end of 2027. Was any such promise made for St. Anne's? And also, what does that mean for the period after 2027? Does that mean that then Lifespan could choose to sort of close inpatient acute care if they wish, and potentially change it to only outpatient care? Or are there any requirements for the period after 2027?
So on the first part of your question, Lifespan did not receive supplemental funding for St. Anne's, and that was why the agreement was limited to Morton Hospital. On the second part of your question, I think that, yes, for all of these transactions, there's an open question of what will happen after the periods for which the parties have made commitments. And I think, we will continue to monitor service provision and maintain communication with the parties moving forward, and certainly hope that services are not reduced in any material fashion. On the next, yes. I will now turn to the acquisition of Holy Family Hospital's 2 campuses by Lawrence General Hospital. The transaction also included employment of some physicians affiliated with Holy Family. In its filings, Steward stated that Lawrence General intends to operate the hospital campuses in substantially the same way following the closing. On the next slide, we have again summarized our key findings from our analyses of the potential impacts of this transaction, which I will walk through in the coming slides. On the next slide, as a reminder, Holy Family Hospital is a community hospital with 2 campuses in Methuen and Haverhill. It is a high public payer mix hospital and is higher priced than many other community hospitals in its area. Both campuses are important providers of behavioral health services, and the Methuen campus is an important labor and delivery provider in its area. Holy Family has generally performed well financially in recent years. On the next slide, Lawrence General is a community hospital in Lawrence. It has very high public payer mix and is moderately priced compared to other local community hospitals. It has a level 3 trauma center and is an important labor and delivery provider in its area. It has had some financial difficulties in recent years. On the next slide, here too, we conducted our normal reviews of market shares and market concentration, notwithstanding the fact that this too was a hospital going through bankruptcy, and found that the transaction does increase market concentration in the parties' service areas, potentially increasing Lawrence General's negotiating leverage with payers. However, we also found that the service areas are small and both hospitals have low commercial volume. We also note that Lawrence General has been historically lower priced and Holy Family is higher priced. To the extent that Lawrence General is able to negotiate prices closer to Holy Family's, spending could increase, but the impact would be limited by Lawrence General's low commercial volume. On the next slide, you can see Holy Family's statewide relative price at the top compared to Lawrence General in red in the middle, and the relative prices of their comparators in orange. On the next slide, we also analyzed potential changes in referral patterns. Steward historically referred patients to high-priced St. Elizabeth's for tertiary quaternary care. After the acquisition, some of this care may shift to other teaching hospitals or academic medical centers with whom Lawrence General already has relationships. Whether this increases or decreases spending will depend on the relative proportions of care that shift to other hospitals. As you can see in the graph on the right, Mass General's AMCs are more expensive than St. Elizabeth's, and the other AMCs and teaching hospitals with a presence in Holy Family service area are less expensive. On the next slide, we also found that the transaction has the potential to improve quality at Lawrence General and expand health equity initiatives at Holy Family. Lawrence General has earned the Joint Commission's Healthcare Equity Certification, and the transaction will provide an opportunity for Lawrence General to share its health equity practices with Holy Family. Holy Family performs slightly better than Lawrence General on measures of patient experience, timely and effective care, and imaging. The transaction offers an opportunity for both hospitals to share best practices on quality improvement. On the next slide, we also analyzed the parties' payer mix and compared it to the overall payer mix in their service areas. Both Holy Family campuses and Lawrence General have higher overall public payer mix than their service areas, highlighting the degree to which these are all important providers of services for these patient populations. On the next slide, most importantly, the transaction ensures continuity of care at Holy Family, an important safety net provider in the Merrimack Valley, allowing it to continue to provide important services, including behavioral health and emergency care. Lawrence General made specific commitments to the Commonwealth in order to receive supplemental funding for Holy Family, including operating Holy Family as an acute care hospital at least through fiscal year 27, maintaining current services at its Haverhill campus for at least 6 months, and continuing to participate in Mass Health. Lawrence General has also committed to participate in a regional collaborative with the administration to advise on reorganization of healthcare services in the Eastern Merrimack Valley. And the acquisition was also subject to the determination of need conditions I described on a previous slide, which related to facility improvements, operations, service changes, and patient access, including a requirement to participate in Mass Health for 2 years. On the next slide, based on the HPC's findings and the importance of maintaining services at Holy Family, and in light of the DON conditions and commitments tied to supplemental funding, the HPC chose not to conduct a cost of market impact review of this acquisition. The HPC completed its review on September 27th, and the transaction was completed by October 1st. Going forward, as with the Lifespan transaction, the HPC plans to monitor cost, quality, and access data for the parties and review materials submitted to the DON program. Again, I'll pause here if there are any questions. Hearing none, let's continue.
Barbara?
Oh, sorry.
Thank you, Megan. Just a real quick question on the Mass Health commitment for 2 years. I know you can't predict what will happen beyond that, but given what we know about payer mix and given what we know about financial stability, is it fair to ask you what your sense is of the probability that they'll continue with Mass Health beyond that time?
I think it would be extraordinary for a hospital to choose to no longer accept Mass Health. I believe that would go along with the condition of not being able to accept Medicare patients.
Mm-hmm. That's what I thought. I just wanted to get it on the record.
Yes, absolutely. I think that would be a very unlikely occurrence. Although the condition also relates to their physicians as well. But in that case too, I feel relatively confident that the parties will continue to support Mass Health patients.
Okay, just double checking, Megan. Thank you very much.
Of course. I will now turn to the 3 MCNs filed by Steward and Boston Medical Center for the acquisition by Boston Medical Center of St. Elizabeth's Medical Center, a teaching hospital in Boston, and Good Samaritan Medical Center, a community hospital in Brockton, as well as employment of certain affiliated office-based and hospital-based physicians by Boston Medical Center. On the next slide again, we have our key findings from our analyses of the potential impacts of these transactions, which I will walk through on the following slides. As a reminder, St. Elizabeth's is a high-priced teaching hospital in Boston, and it has been the referral hub for the Steward network to date. It has high public payer mix and provides important services in its extensive service area, including behavioral health and labor and delivery with a level 3 NICU. Its financial strength has varied a bit over recent years. On the next slide, Good Samaritan Medical Center is a higher-priced community hospital in Brockton. It has high public payer mix and is an important provider of behavioral health and labor and delivery services in its service area. Its financial profile has generally been positive in recent years. On the next slide, Boston Medical Center is a low-priced academic medical center in Boston. It has very high public payer mix and has a level 1 trauma center. Its financial position has generally been strong in recent years. On the next slide, in the normal course of the HPC's review, HPC found this transaction would not substantially increase inpatient market concentration and thus would not be expected to change the parties' negotiating leverage with commercial payers. We also found that the acquisition may lead to a shift in tertiary or quaternary referrals away from other Boston academic medical centers to lower-priced Boston Medical Center, which would be expected to reduce spending. As you can see on the next slide, St. Elizabeth's is the highest-priced teaching hospital among its comparators, and Good Samaritan is the highest-priced community hospital among its comparators. Boston Medical Center, on the other hand, is the lowest-priced academic medical center, lower priced even than its new corporate affiliates, St. Elizabeth's and Good Samaritan. On the next slide, the HPC also found that Boston Medical Center had better quality performance than St. Elizabeth's and Good Samaritan on measures of patient experience and timely and effective care. The transaction offers an opportunity to improve care at the acquired hospitals, particularly given Boston Medical Center's stated intent to standardize patient care across its hospitals. On the next slide, when we analyzed payer mix, we found that Good Samaritan, St. Elizabeth's, and Boston Medical Center all serve a higher portion of public payer patients compared to their service areas overall. Boston Medical Center serves an especially large share of Medicaid patients compared to its service area at 62% versus 28% of inpatient stays, highlighting the degree to which all of these are important safety net providers. On the next slide, most importantly, like with the other transactions, we found that the acquisition will maintain the provision of important services at St. Elizabeth's and Good Samaritan, including behavioral health, deliveries, and emergency care. Boston Medical Center is an important provider of care to Black, Hispanic, Latino, and Spanish patients. Boston Medical Center's experience serving a diverse population will serve it well as it takes over the operation of 2 additional safety net hospitals. Boston Medical Center made specific commitments to the Commonwealth in order to receive supplemental funding for these 2 hospitals, including operating Good Samaritan as an acute care hospital at least through fiscal year 26, and St. Elizabeth's at least through fiscal year 27, and continuing to participate in Mass Health. And the acquisition was also subject to the determination of need conditions I described on a previous slide, which related to facility improvements, operations, service changes, and patient access. On the next slide, based on the HPC's findings here too, and the importance of maintaining services at St. Elizabeth's and Good Samaritan, in light of the DON conditions and commitments tied to supplemental funding, the HPC elected not to conduct a cost of market impact review of these acquisitions. The HPC completed its review on September 27th, and the transactions were completed by October 1st. Going forward, as with the other transactions, the HPC plans to monitor cost, quality, and access data for the parties and review materials submitted to the DON program. I'll pause here for questions and then turn it back over to David.
Hi. First, thank you very much for that presentation. It was very clear, very informative. Just a clarification. So the Lawrence General acquisition is not, they're not purchasing any hospitals that have labor and delivery. So Lawrence General Hospital itself has labor and delivery, but the Holy Family hospitals do not. Is that correct?
I thought one of them did provide labor and delivery services, but I'm going to have to go back to that.
Oh, I think someone's on mute.
I believe
They do provide, Holy Family in Methuen does provide labor and delivery. And the question that's being wrestled with in the working group up there is, you know, what's the best location for that? We have 2 labor and delivery services, both kind of subscale, 1.6 miles apart from each other. So that's one of the things the working group will be working through with the community and the health center, the providers up there.
Okay, thank you very much. I had just been thinking about, well, one, how Boston Medical Center's acquisition of Good Samaritan and St. Elizabeth's will really, you know, expand its footprint in maternity care and in maternity care for communities of color and here in Boston and in Brockton. And I guess I'm just, thinking through the impact there. One, because it looks like there's a promise to maintain services at Good Samaritan through fiscal year 2026. But has labor and delivery opened back up at Brockton Hospital, the hospital that experienced the fire? I don't think so, right? So
Not yet, but it's very close.
It's very close. Okay, I guess I just worry about that community potentially being exposed to further losses of labor and delivery and other critical services. So, just putting it out there that I think it would be that we ought to really sort of keep track of how various service lines are being impacted in this process.
Absolutely.
Thank you very much, Commissioner.
Commissioner Foley?
Yeah, thank you. And thanks for the presentation. And I guess less of a question, but more just continuation of statements that I made last time, just about looking at this transaction and HPC's role in it. Particularly, I think the findings point to, not necessarily a negative impact on cost or market disruption, but really just continuing to focus in on the access to services and care. And I know there's been a lot of work put into getting this into the situation that we're in today. A lot of important hospitals have been saved through this process with significant help and support through the Commonwealth. And we've lost 2 hospitals, and now with Norwood, the satellite sites anyway, closing, and hopefully find a new operator for the hospital there. And, obviously knowing now the timelines for some of these hospitals and the commitments that were made to keep them open for a certain amount of time, I just think it's really important for the HPC to be engaged in that process and those conversations. I certainly don't believe we have the ability to beyond 2026 or 2027 or whatever the timelines are, like losing additional hospitals or service lines without a healthcare plan, which goes to our policy recommendations, is a really good idea. And so just more of a comment. I know, again, I think there's been a tremendous amount of work, important work that's happened to get us into the best possible situation or outcome, but knowing we've lost 2 hospitals through that process, and Norwood, need to continue those conversations, and appreciate there's going to be a conversation about the Holy Family campuses in Lawrence General and a healthcare plan of work, but also the important role of Good Samaritan Hospital and St. Elizabeth's Hospital and Morton Hospital, all within certain timelines and commitments made at least through them. But I just think it's really important that we keep focused and monitoring on that as this develops, because we know the important role those institutions play in the communities that they serve patients, the patient population they take care of, the workforce that delivers that care. I just think it's important that we maintain focus on that as these timelines and this process evolves into the next phase of post-Steward world. Thank you.
Thank you, Commissioner Foley. And we'll just add that to the extent that any of the new hospital operators do close service lines beyond in the time beyond their commitments, they would require an essential services filing with the Department of Public Health, and the HPC will certainly be monitoring those filings closely.
Any other questions or comments before we close on the HPC review of the hospitals? I want to underscore the other commissioners' comments about moving to this next phase around implementation, where we're all rooting for the new operators as they delve into management of these facilities, and look forward to staying involved with the OHHS and also with the new organizations to track what comes next. Secretary Walsh?
just wanted to offer my thanks to the HPC team who has really been incredibly helpful to me as we sort of guided this through, and also very available. A lot of the data that we looked at came from them in a working group that which had HPC members, DPH members, labor. This regional look that we took at each of these challenges, I think, really helped inform the process. It's not perfect, as my friend Commissioner Foley pointed out, but there's I think we're in a good place. And the only thing I would say about the time commitments is they were really linked to funding commitments, and it was very hard for the state to go beyond the funding commitments that were embedded in the 1115 waiver, which expires in 2027. So sometimes the commitment is really a funding commitment, not a service commitment. And our understanding from having dealt extensively, negotiated very directly with all of these providers, is that they are really committed to these regions and are really thinking about, in the places where we were able to save hospitals and where hospitals had to close, this is all about reimagining what healthcare could be in that region. And so, and stabilizing critical access points across the safety net. Morton Hospital as a standalone was going to have a very difficult time. Same with Lawrence General. And so putting these systems together, but we could not have done this without the HPC's help and the occasional therapy session that David Seltz offered me. So I just want to express my gratitude publicly. Thank you.
Thank you.
Thank you. And we would also say that it was on the part of the leadership team and the board, terrific to see you lead and conduct this process, Secretary Walsh. Thank you. Other comments or questions from any commissioner before we move, Dr. Cutler?
I just wanted to pick up on one thing the secretary said, which is with these transitions, we get a chance to think about running healthcare in a different way. And I think we now have 3 new health systems that we hope will operate in different ways than many health systems have in the past. And as a board, we've highlighted a number of things ranging from payment models to collaboration to use of IT and so on that we thought would be helpful in helping health systems run smoother and more efficiently. And so we ought to at least think about how we can bring some of that interest work that we've done into these situations, not to be overwhelming, but to be there to help out with some of the things we've learned and some of the things we feel like we can move as a Commonwealth move forward on.
Great point. Yeah, I've been restraining myself from expressing excitement about what's to come, but I do feel it. I feel like there's tremendous opportunity given the organizations that are now managing these 5 hospitals and their demonstrated track record and long-term commitment to the types of challenges that they're now going to take on with the newly acquired entities. So I think it's great to reflect that positive potential. Other comments, thoughts, questions? Any commissioner? Okay, with that, we will officially close on this chapter of the examination of the Steward Hospital transactions, and we'll move to discussion of the current findings in the Rural Health Group transaction.
Thank you, Madam Chair. And maybe just an epilogue to that chapter. Some of the comments by commissioners here about this, an opportunity for a reimagining of healthcare, about opportunities for delivering a different type of care, systems that are focused on putting patients first. These are themes that we really hope to explore at this year's cost trends hearings. We see this cost trends hearing as an opportunity in some ways to turn the page. Not to say that we shouldn't examine very closely and make sure that we learn the right lessons from the Steward Healthcare bankruptcy and dissolution and failure. But there is also this opportunity in the future. And so I hope that you think now about those questions that you want to be asking our witnesses and those themes that we can bring forward at the cost trends hearings. And it will be a great opportunity to engage the broader marketplace in that next chapter for Massachusetts. Transitioning now to our discussion and update on our review of the Stewardship and Rural Healthcare Group transaction. Commissioners, we want to provide today an update to you on our preliminary review of this transaction and our findings to date. We are at the very, I think, end of our preliminary review, reaching the end of our review. And so today we're going to be sharing our findings with you and hope to get your input and questions on these findings. As an introduction, and I know all of the commissioners here know this, our role here and our current authority is not to approve or deny a transaction. Our role here is to review these transactions on behalf of the public and assess impacts on cost, quality, and access, and make these findings public. And through this, we hope to provide greater public transparency and accountability. And under the current law, as you know, we do not have the authority to impose or require enforceable conditions of transactions, although we may seek voluntary commitments and public statements from the parties to mitigate concerns. And so while our tools may be limited, I think we strive to use our tools to the greatest impact possible for the greatest good of the public here in Massachusetts. In this transaction, we have been under an intensive review in a very short time period. We've received these material change notices in mid-August, and this is a unique set of facts and a unique set of parties for review by the HPC. I do want to recognize the cooperation of the parties under review here. Rural Health Group and Stewardship have been cooperative throughout this process. They have been providing the documents and information and data that we have been requesting in a very timely fashion. It's been an intensive review over the past 2 months. We have been reviewing extensive confidential material in the course of this review, some of which we will be discussing here today. And I'm pleased to say that in the course of the review of many of this confidential information, we did see that those confidential materials, including materials that reflected statements to investors and lenders, that they aligned with the statements that they were making to us throughout this process. So with that as just an introduction, I am again pleased to turn it over to Megan to walk us through our findings at this stage of our review of the Stewardship Rural Health Group transaction.
Thank you, David. As David previewed, I will now walk through our initial findings on the acquisition of the Stewardship Physician Group by Rural Healthcare Group. I want to first echo David's comments that the parties have been very helpful as we've worked to complete a very thorough review in short order. Rural Healthcare Group has also authorized us to make a number of disclosures of confidential information, which we have included throughout our presentation, that will provide more transparency for the public regarding RHG's plans, and in many cases directly respond to feedback from commissioners in the September board meeting. As Kate will describe later, Rural Healthcare Group has also made some voluntary commitments to the HPC. On the next slide, as a reminder, Stewardship Health includes both employed physicians in the Stewardship Health Medical Group and the broader physician contracting network, Steward Healthcare Network, as well as a large number of advanced practice providers and administrative and other non-clinical staff. As of 2022, Steward's Physician Network was the third largest contracting network in Massachusetts, with approximately 2,950 physicians reported into our Registration of Provider Organizations program, accounting for approximately 10% of all physicians in Massachusetts. Of these, approximately half were employed, approximately 400 were primary care physicians, and the vast majority were specialists. This total includes more than 500 Cape Cod physicians, which we understand are no longer contracting through Steward. We also understand that approximately 600 hospitalists and office-based specialists affiliated with the Steward hospitals, whose sales we reviewed, are expected to be employed by the acquiring systems. So the number of physicians who will remain in the network that RHG is proposing to acquire would be somewhat reduced. On the next slide, as you can see by the map on the left, there are stewardship physicians across Massachusetts, particularly in the eastern and southern regions, in many of the same geographies as the Steward hospitals. The size of the circles reflects the relative number of physicians practicing in each area. The two maps on the right break out Stewardship's primary care physicians and specialists, emphasizing again that the majority of Stewardship's physicians across eastern Massachusetts are specialists. On the next slide, a physician group acquisition of this size with physicians in Massachusetts and 8 other states will significantly increase the proposed acquirer Rural Healthcare Group's physician operations. Founded in 2022, Rural Healthcare Group is a new but rapidly growing private equity-backed provider organization with 17 primary care clinics in North Carolina and Tennessee. Rural Healthcare Group's affiliate, Brady Health Buyer, which submitted the MCN filing, is a management services company set up by New York-based Kinderhook Industries to purchase Stewardship. Kinderhook Industries, which owns both Brady Health Buyer and Rural Healthcare Group, is a private equity firm begun in 2003 that has raised a total of $8.5 billion in capital and has 7 active healthcare holdings, including other physician groups, pharmacy services, health screening services, and communication support for the deaf and hard of hearing community. For the rest of this presentation, I will be describing the acquirer as Rural Healthcare Group, or RHG. On the next slide. In our thorough review of this proposed acquisition, the HPC did not uncover any significant red flags. This slide reflects many of the confidential disclosures that RHG has authorized us to make so that we can provide important transparency about the overall plans of this new entrant into our market. That said, the HPC would like to emphasize that there are many unknowns accompanying the entrance of such a relatively new provider backed by private equity that does not have a past history in Massachusetts. Rural Healthcare Group has detailed plans to establish a new corporate structure for stewardship assets that largely mirrors the existing stewardship structure, facilitating continuity of operations. As a general for-profit entity, RHG is prohibited under Massachusetts state law from directly owning clinical practices. RHG would instead provide management services under a management services organization, or MSO, to stewardship clinicians who, under a professional corporation, would provide clinical care without improper influence by RHG. This friendly PC and MSO model is a common structure in Massachusetts, and RHG has emphasized that the MSO has no ability to interfere with or control medical decisions by the PC. RHG is expecting to retain much of Stewardship's leadership and nearly all clinical and non-clinical staffs to support operations in Massachusetts. RHG does not anticipate changes to hospital admission privileges for the stewardship physicians. On the next slide, we describe our findings regarding prices and market share. Steward's physician prices are low to moderate for commercial payers in Massachusetts. While Stewardship is quite large, as the 3rd largest physician group in Massachusetts, Rural Healthcare Group is a new entrant into the market, and so the acquisition will not increase market concentration in Massachusetts. On the contrary, given that some physicians are leaving Stewardship to join the networks of the hospital acquirers, and may also leave to join other networks, Stewardship's market share is likely to decrease after the transaction. Given that the parties' bargaining leverage is not expected to increase, the transaction is not anticipated to increase Stewardship's prices. On the next slide, while Steward's health status adjusted total medical expenses, or TME, has been moderate, it has had high and rapidly increasing unadjusted TME in recent years. Steward's high unadjusted TME suggests an opportunity to reduce spending through changes in utilization, particularly by reducing unnecessary hospital utilization, given that Stewardship will no longer be corporately affiliated with hospitals. While Rural Healthcare Group stated it does not anticipate changes to referral patterns in the near term, to the extent that its independence from the former Steward hospitals, which as described above are higher priced than some of their local competitors, leads to a shift in referrals to lower cost facilities, this could moderate spending increases in the future. Rural Healthcare Group has also emphasized its focus on value-based care arrangements, which will incentivize it to provide care efficiently. On the next slide. Regarding quality, the HPC again emphasizes that due to RHG's limited track record in managing physician practices, it has limited information on which to evaluate the potential of the transaction to impact Stewardship's quality of care. However, Rural Healthcare Group has described plans to implement several changes at Stewardship to drive quality improvement, including in care management and care coordination. Rural Healthcare Group also plans investments in analytics and technology, including restoring and enhancing EHR functionality for Stewardship practices. Rural Healthcare Group's planned investments in the practices alone, which under Steward have had underinvestment in recent years, may increase quality to some degree. The limited data available from Rural Healthcare Group also suggests relatively strong quality of performance for RHG's current practices to date across most metrics. The financial incentives from value-based contracts suggest these changes could have some positive impact on quality. However, the HPC is unable to assess their likelihood of success given RHG's limited history. Overall, the HPC found that the transaction is unlikely to reduce quality and has the opportunity to improve quality for Stewardship. On the next slide. Regarding access, the HPC reviewed this proposed transaction with the understanding that the alternative to acquisition by Rural Healthcare Group would likely be to let the network dissolve and for other networks to acquire physicians and practices piecemeal over time, which would be disruptive for patients, physicians, and other Stewardship employees. Stewardship is an important provider for patients with public payers, with a 58% public payer mix for its medical group in 2022. Particularly given the alternative, acquisition by Rural Healthcare Group will allow for continuity of care and access for patients during a tumultuous time for healthcare in Massachusetts. Rural Healthcare Group stated it is committed to maintaining access for the current patient panel, including MassHealth patients, and to growing patient panels with all payers. Rural Healthcare Group has also committed to providing updates to the HPC regarding the patients it is serving. The HPC will be able to monitor trends in payer mix and demographics of Stewardship patients through our Registration of Provider Organizations program and All Payer Claims database, respectively. Rural Healthcare Group also stated plans to increase access to primary care services, including by increasing its primary care patient panel. RHG also emphasized that its business strategy for generating profit is through quality improvement, participation in value-based contracts, and growth in volume, rather than by cutting internal costs or services. I will now turn it over to Kate Mills to discuss Rural Healthcare Group's voluntary commitments and summarize our findings.
Thank you, Megan. On the next slide, in addition to permitting us to disclose a lot of the detail in the previous slides that Megan went over, RHG has made some important commitments to the HPC. So first, I want to acknowledge that RHG has committed to fully complying with all state transparency and market oversight requirements, including participation in the annual cost trends hearings, and it has committed immediately to report into the Massachusetts Registration of Provider Organizations program and to reporting annually thereafter. Obviously, this is the law, but it is also a critical commitment given that Steward did not make its required financial filings to the Registration of Provider Organizations program in the past. And these are publicly available data that will allow for ongoing insight, both by the HPC and other interested stakeholders, into RHG's operations in Massachusetts, and would include, for example, organizational charts and other key information on the structure of the organization, financial information, audited financial statements, physician rosters and NPIs and other linking data, information on relationships with other providers in the state, contracting relationships, clinical relationships, and detailed information on payer mix, as well as other information. Critically, RHG has also committed to providing periodic updates to the HPC on its operations over the next 2 years, including but not limited to updating on changes in personnel, recognizing that some of these numbers are changing and candidly won't be known with some degree of certainty until the future. They would report any changes in services, updates on the patients served, as well as updates on any significant financial activities that could impact operations in Massachusetts. That, of course, would give us the opportunity to ask about things like significant sales of stewardship assets and other types of financial activities that could be potentially destabilizing. And finally, as you see acknowledged here, RHG has stated that it's aware of they are aware of the fact that some private equity investors have engaged in behaviors that have been destabilizing to some of the companies in which they've invested. And so RHG has stated and was willing to state this publicly, that it's committed to the long-term success of stewardship for the benefit of its clinicians, patients, and the broader Massachusetts communities, and that it does not intend to engage in any behaviors that would destabilize it. On the next slide, you see really just a summary of all of these findings to date, which Megan walked through in detail. Just to summarize, as we've previously emphasized, the transaction does contain many unknowns, given RHG's limited history and connection with private equity, given the fact that they are a new entrant to the Massachusetts market. But it does provide an important opportunity to allow the stewardship providers to continue to provide care in close to the same structure as they provide it today. It will also not increase market concentration in Massachusetts, and the employment of some stewardship physicians by hospital acquirers will actually likely reduce stewardship's market share over time. So we do not anticipate that this would increase prices. RHG's planned investments in stewardship, including in care management, care coordination, and technology, are likely to offer greater stability to the stewardship practices. They also have the potential to improve quality. As Megan described, stewardship is an important provider for Medicare and Mass Health patients, and RHG has committed to continuing its participation in Mass Health and has stated that it does not anticipate changes to stewardship's payer mix. And of course, as noted, we would be able to monitor that going forward through the registration of provider organizations program data. RHG has also emphasized that its business strategy is through quality improvement, participation in value-based contracts, and growth of volume, rather than, as noted, internal cuts or cuts to services. And then finally, as I just described, RHG has made important commitments to participate in state transparency and market oversight efforts, and also to providing ongoing updates to the HPC on its operations, including financial activities. And I will pause there. And we are happy to answer any further questions.
Thank you, Kate. And just to reiterate again, we are nearing the end of our preliminary review here, and so seeking comments and feedback from commissioners. One important note that was on the first slide here is that the state and federal law enforcement agencies have all closed review of this transaction. The federal law enforcement agency, as well as the local state AGO's office, have closed review. So wanted to make that point clear as well.
Secretary Walsh?
So I had one comment and one question. The first comment is to underscore some of the comments that the HPC staff experienced. I've had some dealings with rural health groups leadership. Had to call them on Labor Day weekend because with the Neshoba closure, the building systems were connected to the medical office building, and they kind of sprang into action to make sure that people could have access to see their doctors on Monday morning, which I greatly appreciated. And then we had another kind of hiccup, like on a Sunday evening before we had to close just a few days ago. And again, they were very helpful. So I would echo the comments that they're certainly trying to behave in a way that is consistent with the values of our state in terms of quality and access and commitment to patients. The question I have is, and I don't know if we talked about it or whether our purview is, did they talk at all about their exit? Because they are in this to make money, and I think that as we look back on the stewardship, on the steward challenges that we experienced, and the kind of flipping of the assets a couple times, and reflecting on Dr. Zong's presentation to this group, I hope I'm pronouncing his name right, about the role of private equity. David, you and I had a brief conversation about this, but is there, have they signaled kind of their intent, their duration, anything that would help us think about this? Because that's the one thing I didn't hear in the presentation.
I can start us off. So we did have conversations with the parties about this topic. I will say, unfortunately, that those were confidential conversations, and we did not ask for the parties' authorization to discuss them publicly. So we may need to follow up with you subsequent to this. But I will note that those ongoing communications that we would be able to have with the parties, we could also talk to them about future plans at that point too, so we could.
But it's been part of our review. It's been part of our.
Correct. It was part of our review.
Thank you. I appreciate that, and I didn't mean to ask you to spill the beans. Sorry.
Just to put a fine point on it, we did learn from Kinderhook about its track record, its typical time horizon, which we have learned about, and their track record of who they sell to. And typically it's not another private equity firm. It's typically another kind of strategic business entity who's interested in continuing the business.
Great, thank you. That's actually what I was looking for. Thanks.
Commissioner Cutler?
So I have much more mixed views about this transaction than about the hospitals. In part because the hospital owners we have a lot more of a track record with, and this one we do not as a Commonwealth. And it is sort of ironic that we're in this trouble in part because of private equity, and the solution is therefore to sell to more private equity, which strikes me as a little bit off. I guess so I'll say the negative things first and then come back to some more positive things. So the negative things is I don't care what they say. I don't care what they say about, like, we're going to do a great job, we're going to do whatever. I'm sure Steward would have said exactly the same things at exactly the same point. Talk is cheap. Who cares what they say? I care about what they do. And the way that it was described, what they want to do is kind of run the Steward doctors better than Steward was able to run the Steward doctors. And that's a reasonable statement. I have no idea if it's possible or not. Like, I don't know how good Steward was at running the doctors. I don't know how good RHG is at running the doctors. I don't know how good Kinderhook is at helping RHG to run the, like, I just don't know about that at all. And what worries me is not that, the primary way they intend to make money is by doing things that are, to be blunt, screwing the Commonwealth. What worries me is that if they can't make their primary way work, they will then be forced to turn to some of those other methods of making the money work out. The good news here is there's not as many assets to plunder. So, you don't have the hospital building, you don't have the land and so on, but, you can always shortchange on the salaries and cut the staff and, cut the equipment and so on and so forth. So I'm not saying that's going to happen, but that's my worry, is that if they can't make plan A work, what happens with plan B? I think we being the Commonwealth and we being HPC, should really be monitoring very closely here, in part because there isn't a track record here, and because we want that, in part because of private equity, and we understand the incentives there, so that if we see things that look like we're going to go down on staff, and we're going to, we're going to shortchange the patients, and we're going to do whatever, that we be in a position to call foul right away, and to be in a position to act right away, than to sort of wind up, with Steward. I think, if the Commonwealth had a capacity to act earlier, we would have all been much, much happier about it. So that's on my worry list. On the other hand, these are real people. These are real patients who need care. These are physicians who are just trying to practice medicine their best. These are workers, staff workers, and clinical assistants, and so on. And they deserve a chance to have a go at it with an ownership structure that's not terrible. And so rather than the thing just disappearing piecemeal into every other thing and just creating havoc for patients and staff and clinicians and so on, we actually deserve a chance to make this work. And, we know there are other, at one point there were various other possible buyers, and we know there are various difficulties associated with all of them. So it's not like there's someone out there who, in my mind, I'm saying, gosh, I wish they would have bought. And, then I would feel totally comfortable, because there just isn't any. And so they really deserve a chance to make it work. And if we're convinced that these folks will really try and make it work, then that's on the good side. And then if we can just, keep monitoring and be prepared to, use the umpire's whistle or the referee's whistle as soon as we need to, then, that can make me feel as comfortable about it as we can in what is, just overall, obviously, just a terrible situation. So I fear I've ranted on too long, but that's kind of where my thoughts are on it.
Very helpful. I think you've said a lot of the balancing that is going through the minds of several of the commissioners in terms of both the positives about this and the opportunity there, but also the concerns in general about private equity investment. Commissioner Blakeney?
Thank you, and I appreciate following Commissioner Cutler's comments. I want to start by first saying, given where we started and given the utter chaos and catastrophe that could have happened, that we are in a much better place than I thought we could possibly be. Acknowledging that and congratulating Secretary Walsh, the governor, the entire governmental structure that was engaged in this to get us to this point, I don't think we should forget that, and I don't think we should stop acknowledging that. Having said that, I feel concerned that another private equity company is involved. I think given the resources and the regulatory power that the commission and that the state has, we've gotten assurances that we have now made public and that we now have a commitment from the company they will in fact engage. I think the minute if they don't, I'm with Commissioner Cutler, we call them on that. But basically, I still believe, I've said this before, I'll say it again, private equity is a predatory process. It has no business in healthcare, and it has no business in social services. And I look forward to Senator Kerry and Senator I look forward to our federal government taking some action to try to limit their ability to move this forward. In the meantime, I hope that the state can continue in its thoughtful process of finding a way to really limit, if not eliminate, the private equity model in healthcare. It's got no business here. I hope we find a skillful way of limiting their ability to engage. Thank you.
Thank you. Commissioner Foley?
Yeah, I mean, ditto to what all the questions and comments that were made prior to me on this. I think I agree with nearly everything that's been said. And I think we're all we're in a really difficult situation at the same time. I don't think there's many other options that we have other than to move forward here and move beyond Steward. I feel like this is kind of the last big block before we can officially say we're in a post-Steward world. And I think it's a really good sign, and I appreciate the leadership of the HPC on this to get some of these conditions or disclosures and accountability and oversight that we didn't have before and will have going forward. I think this company needs to understand, I think it's been clear stated here today and our past track record and where the legislature wants to go, that there's a deep concern about private equity investments in healthcare. And that we are going to be watching this very closely to ensure that all these commitments are maintained. And if not, used every tool in our toolbox and hopefully new tools that we get through the policy recommendations in the legislative process to hold them accountable. But I agree that we have to move forward here, hold them accountable to the commitments that they made, and urge legislative action to give us the tool necessary to take action when required. And so I deeply appreciate the work of the HPC staff. I think this is the best outcome within our role and the powers that we have in this process that is possible. And I think it's a clarion call for action to give us and other entities in the state more power and authority and tools to hold people accountable, particularly private equity investors in healthcare delivery in Massachusetts. And so I look forward to the discussion later on about our policy recommendations and ideas and suggestions that we have to do our jobs more effectively and to meet the mission of the Health Policy Commission.
Thank you, Commissioner. And I do want to comment that in making these public commitments, Rural Health Group is trying to create a good relationship going forward, and that they are committed to following through on reporting and data, which the Steward never was. So making that commitment, instead of saying we need to see what the realities are once we begin to operate, making that commitment proactively was, I think, a very strong indication to us that they want to, as David Salt said, turn to a new chapter on this. Commissioner Cohen?
Yeah, I want to just echo what my fellow commissioners have said. I think we have no choice here in that we have practitioners and patients who are relying on the care that's being provided here, and we need to see it continue, because I think without that, I fear what will be a further destruction of our healthcare system. But for me, and as Tim just said, what this really means is we need more tools and more authority to properly monitor these kinds of investments going forward. I think for us, this is really about the sort of limited authority, and we're the only entity in the country evaluating this transaction, yet our power is pretty limited. So I really think this goes back to actually the next agenda item, which is the policy recommendations, because if we don't strengthen those, we're going to see more of this in the future if we continue to see this kind of investment.
Thank you. Commissioner McGregor?
Yes, thank you. Also wanted to echo many of the comments that were made and thank Commissioner Cutler for raising what I think many of us also have wanted to say, which is that we are skeptical of the promises that any private equity-backed entity is making at this point. We've seen just how damaging the fallout can be. And frankly, in many ways, private equity does not mix with healthcare, especially healthcare for some of our most vulnerable patients across the Commonwealth. That being said, I just had two questions. The first being whether Rural Health Network has responded to the letter that Senators Warren and Markey wrote to its CEO recently, essentially asking them to explain their connections to a software company that has a history of developing algorithms that were used by insurers to improperly deny healthcare for patients. So there were a couple of concerns that the senators made in that letter on September 29th. And I was just curious if we knew whether or not they had responded to those concerns. The second question is to follow up on a recommendation that Commissioner Cutler also raised, which is that we ought to use this opportunity that we have here, this sort of post-Steward world, to really apply and implement some of the strategies around payment reform, monitoring quality of care, et cetera, that we've been wanting to use. And I wonder whether we know anything about rural health groups' EHR system and what EHR system that they're planning to use, how that will sort of communicate with the EHR systems at existing hospitals. How will the hospital systems here in the Commonwealth sort of be able to communicate with sort of the outpatient care that patients are getting? So those are my two questions.
Thank you. Lois, do you have an answer on the first question?
On the first question as to whether Rural Health Group has responded to Senator Warren, Senator Markey's letter specifically, I am not aware if they have responded to any of those questions about Navi Health specifically.
And if I could just add, we are in receipt of that letter that came from Congress. As part of that letter, there was a request for certain data and information from the parties, and nearly all of that was part of our review and has actually been disclosed as part of today's presentation.
Okay, great.
On the question of their EHR, I can't respond specifically on the EHR because we haven't been authorized to disclose what they have told us, but I can say that they are committed to maintaining the relationships between stewardship physicians and their referral partners to maintain continuity of care. So I would be very surprised if their EHR didn't work with stewardship's current affiliated hospitals.
We can follow up on that.
Yeah, and I would just say I don't think it's a secret, but Stewardship was using the Athena Health system for their EHR, and my understanding is that the plan, at least in the near term, is to continue to use and potentially upgrade that system.
Okay, thank you so much.
Secretary Walsh?
The only thing I would add, which may add more confusion to this conversation, is each of the hospital acquirers is making a decision about an EHR as well. And so I think, kind of what was before will likely change in the future. To me, the most comforting thing is the commitment to those acquirers rather than another system. Because if the primary care base leaves the acquiring hospital, they're going to have that much more of a financial hill to climb. So I think it's a really important point. Can they communicate? But I think both sides could change. The physician side could change, and I expect the hospital side will change.
Thank you.
So maybe more of a detail than we needed, but
no, that's helpful. And I think we will have opportunities to understand some of the challenges and the approaches that the acquiring entities are going to take once we get beyond this first step and the acquisitions are complete. We'll have an opportunity to delve into that further. Other questions or comments?
I have one last comment. Oh, sorry.
Please.
Oh, yeah, I don't know if my hand was up or down, but I guess I just want to, this is obviously, it's been a very long and challenging summer for all of us, or year for me, as it related to Steward and a bankrupt health system and a very compressed geography and in gateway cities with a lot of jobs in patient care at stake. And it's really easy to get caught up in the kind of never again rhetoric. When I think about this from the perspective of, and I think I'm on this commission as a representative of the Healy Driscoll administration, and I think about, the governor's 3 key priorities, which are affordability, competitiveness, and equity. I think about the life science industry in our state, which is sort of the envy of the world and largely a product of venture or equity funding. Like, I think we really, really need to be careful about our rhetoric here. I see David Cutler nodding, so maybe I'm right for once on an economic topic. But I just want to be sure, and believe me, I've had my moments of kind of raging at the machine here. But I think we as commissioners have a responsibility to think broadly and deeply about this and not react. I've said this before, but I saw this in the flurry at the end of the last legislative session. My mother used to say, marry in haste, repent in leisure. I think legislate in haste, repent in leisure. I think we really need to think about what it is we're trying to accomplish here. And when somebody steps up with a track record, substitute private equity for Citizens Bank. Like, people need equity to work and frankly to change the system, and what we saw in Steward was underinvestment. We need people to invest in the system so that it works better. So I just wanted to say that, with acknowledging all of the very legitimate emotions and concerns about this, that we have to be really careful as we move forward, and also very cognizant of our current range of authority. So I just wanted to say that.
Thank you. Commissioner Cutler?
So first I want to give the secretary a degree in economics because she clearly has earned it. But
My Econ 10 grade was not something to be proud of, but
it turns out I have the right to go back and adjust that, so that's okay. I had actually wanted to make a point which is very similar to the secretary's, which is that many things can be either good or bad. It depends how you use them. And the secretary made the point about private equity, and Alicia made the point about algorithms. And I sort of feel the same way, right? Like, a really good algorithm is fantastic because, like, a really good algorithm would find people who need help and help them. And as human beings tend to overlook marginalized people, an algorithm doesn't have to do that. On the other hand, a really bad algorithm can lead you astray, and a really bad set of incentives in private equity can lead you astray. And so part of what makes this all very difficult is that it's not so much the sort of name of the thing that matters, but it's how it's implemented that really matters. And one of the things that we can do as a commission that, federal agencies have a hard time doing, they have a hard time monitoring what's actually going on. And so therefore, they have to write these rules in advance, like no this, yes this, and so on. And we can, I think, do a better job of monitoring things as they happen, so that if something looks like it should have a good effect, but it actually is not, then we ought to be able to be there sooner. And again, maybe I'm reflecting that I feel like we as a commission, me as a person waited, I should have spoken up about Steward earlier. Lots of us should have, and maybe that sort of convinces me that we do have to be, just the label of what's happening is not enough, but we have to be really, really involved with how things are playing out, and therefore what incentives are being transmitted, what then happens to patients and workers and so on as a result.
Thank you. And I think that commitment to working with the hospitals by Rural Health Group will be one of the things that we can, understand your point, Commissioner Cutler, as these relationships are beginning to form. That'll be an important indicator. Other comments or questions for the team about the review or specific findings? Any other questions? I do want to take a moment to just acknowledge the extraordinary level of effort for a team. I don't often stop to acknowledge the team because we have an excellent team that is used to producing very rigorous assessments and doing that efficiently. But I will say this was an extraordinary situation, and we all appreciate the level of insight, both what we can share publicly and what was provided confidentially, and the commitments that were asked for and made in this process is really extraordinary. So I really want to recognize the team at the HPC on that. Any other comments? Questions? If not, then I will turn it back to Director Seltz and to Director Mills on other notices of material change that we've received.
Great, thank you, Chair DeVoe. And on the next slide, you all know this slide very well, summarizing the material change notices we've received to date. We are now up to 182 provider transactions, and of these, the formation of contracting entities remains the most frequent. And on the next slide, as you know, we continue to have one active cost and market impact review regarding the proposed transaction between Dana-Farber, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty physicians at Beth Israel Deaconess Medical Center. On the next slide, we continue to work closely with the parties as they finalize providing information to us in response to our information requests. That production is not yet complete, though we are in the final stages. So while this is the overall timeline, please know that our clock continues to be temporarily paused while the parties complete production to us. But we have very much appreciated the parties' continued collaboration with us to provide the information to support that review. And we look forward to speaking about this more in depth in the coming months. And on the next slide, additionally, since our last meeting in September, we've elected not to proceed to a cost and market impact review on one transaction beyond the Steward Hospital transactions that we just described. So specifically, the HPC completed its review of the formation of a new contracting entity, Optum Health Networks, by Optum, which is a subsidiary of United Health Group. United Health Group proposes to create OHN to negotiate risk contracts on behalf of independent physicians and facilities that may seek to participate in the Optum Care Network in the future. The Optum Care Physician Network in Massachusetts, as I'm sure most of you know, currently includes Atrius, Reliant, and MedExpress. This MCN was solely for the creation of that Optum Health Network contracting entity, and Optum will file new notices of material change when enough physicians propose to actually join that network that those affiliations would meet our filing thresholds. We therefore expect to assess the potential impacts on spending, market dynamics, quality, and access of those physician movements when those future notices are filed. And on the next slide, we also have the following transactions still under review. Obviously, the stewardship transaction that we just discussed. And then we also continue to have under review the proposed creation of Northeast Orthopedic Alliance and an affiliated management services organization by 4 existing orthopedic group practices in Massachusetts and New Hampshire, and the consolidation of the operations of those 4 groups into the Northeast Orthopedic Alliance organization, as well as a proposed contracting affiliation between Mass General Brigham and Healthcare South, which is an internal medicine and pediatric primary care practice with 9 locations on the South Shore, which is currently a contracting affiliate of Tufts Medicine Integrated Network, but which would now be proposing to contract with payers through the MGB network in the future. And on the next slide, finally, the proposed acquisition of Vibra Hospital of Western Massachusetts, which is the for-profit owner and operator of both an inpatient long-term acute care hospital and a skilled nursing facility in Rochdale, Massachusetts, by Everett Hospital, LLC, which is a newly formed Massachusetts corporation in coordination with Inequities, LLC. And then since our last board meeting, we've also received material change notices on 2 new transactions, which you see described here, the proposed acquisition of Alden Court Nursing Care and Rehabilitation Center by South Coast, as well as the proposed acquisition of Rotech Healthcare, Inc., which is a national provider of home medical equipment by Owens & Minor, Inc. And we will, of course, be in touch with commissioners on findings and recommendations for all of these as soon as that information is available. Pause there in case there are any questions before I hand it back over to David.
Not seeing any. Any final questions or thoughts on these reviews? Okay, I think we can now move to our next agenda item, which is discussion of the final healthcare cost trends report and policy recommendations.
Thank you, Madam Chair, and thank you, commissioners. And as I have the microphone back, just briefly, just to close out on the previous conversation, I just want to thank all of you for your really thoughtful comments and feedback. I share many of your thoughts and feelings as well. And, you know, you have my commitment as we move forward that we will use every tool at our disposal at the HPC to be a vigilant monitor on behalf of the public watching this transaction and others to make sure that we continue to have a well-functioning market that puts patients first. And we will be looking closely at this and other transactions. So I thank you for your support and thank you for the kind words of the extraordinary work of this team. As has been mentioned, without the HPC, none of this information would have been public. None of these commitments would have been public. So it is a testament to this organization and to the wisdom of the legislature 12 years ago to create the HPC for this very purpose. But 12 years in, it is time to evolve our authority and to perhaps give us and others some additional tools as we think about the challenges of the future. So that is where I hope to shift our conversation in this next agenda item as we talk about policy recommendations to the legislature. These are going to be in addition to our cost trends report. Next slide, please. I think you all know what the cost trends report is. It is our annual report on healthcare spending. It includes a chart pack as well as an interactive dashboard on our website. Next slide. I covered this at our last board meeting. In this year's cost trends report, we had 2 main chapters, one focusing on spending and affordability of care, a second focused on variation in treatment intensity, as well as chart packs focused on a variety of topics that we revisit year after year. Next slide. Just as a reminder to commissioners and to the public, in addition to the written report, which pending the commissioners' vote today, will be available on our website today. We also have interactive visualizations, a performance dashboard, and also highlights from the report that will also be on our website. I'm not reviewing today findings from the cost trends report itself. We spent a fair amount of time at the last board meeting going through the findings of the report. Instead, today, I hope to focus our conversation on the policy recommendations, which will be included within the cost trends report. and then propose a vote to the commissioners to release that cost trends report with the policy recommendations. So next slide. So at the last board meeting, I presented this proposal as an opportunity this year to focus our policy recommendations, really thinking about this opportunity in the wake of the Steward healthcare bankruptcy and dissolution, to have our recommendations speak to what needs to happen next in terms of our response as a Commonwealth in order to protect our system from predatory actors, to strengthen public accountability and transparency, to confront some of the market dysfunctions that led to and created the environment for the Steward healthcare and that drive consolidation in our healthcare system, and ultimately have a vision for, as we've talked about already today, reimagining, rebuilding, and transforming a healthcare system that meets and achieves the values of the Commonwealth that we have been striving for so many years. We had a great discussion at the last board meeting about some of those ideas. In the intervening weeks, I've shared with you some text and some language about policy recommendations for inclusion in the cost trends report. And so today I'll go through those and then we could have a discussion about their inclusion in the report. Next slide. So here's our proposal for the summary of the 2024 policy recommendations to be included. It is, as I said, a more focused set of recommendations than in previous years. That is not to say that we don't continue to think that the other recommendations we've made in previous years are not important. In fact, we continue to think that they're very important. And in the text of the recommendations, we highlight that and call back to the recommendations of the recent years and say that legislators and policymakers should absolutely consider these other recommendations as complementary and necessary with these recommendations. But here, given this specific opportunity, wanted to focus on this particular topic and what needs to happen to strengthen our market oversight and build towards the future. So the first is really around strengthening and expanding our state's market oversight tools. And here, our recommendation is not a new one, but is really around expanding and strengthening our process for receiving material change notices and being able to review those and perhaps to be able to impose conditions on transactions that come before the state for review. The second is around expanding and strengthening our state's transparency requirements, primarily through the state's registration of provider organizations program, which Kate talked about before, which collects a fair bit of information about financial information, organizational structure, and payer mix and other important information. The third is an opportunity to think more forward-looking, an opportunity to revitalize health planning, to ensure that the supply and distribution of our healthcare services aligns with the needs of patients in our communities, to revitalize an effort to conduct these focus assessments of need, supply, and distribution, and to use those focus assessments in our regulatory processes, such as the determination of need process, the essential service closure process, as well as the material change notice process. And then finally, we recognize that there are some long-standing pricing and market dysfunctions that create opportunities for actors to profit through actions that do not create value for patients or for the healthcare system. And so we make recommendations here around addressing long-standing inequities in provider pricing, including requiring site-neutral payment, as well as adopting an out-of-network payment default rate. Many of these recommendations are not new to this commission. Many of these recommendations have been under consideration by the legislature in previous years and in this past legislative session. But together, this is a very strong package of reforms that, if passed and implemented, would be an incredibly bold step forward that would put us as a Commonwealth in a much stronger position to be able to protect our system and to plan for a better system moving forward. I have slides after this that provide a little bit more detail on any one of these 4 recommendations. So happy to kind of dive in deeper on each of these. I kind of did this at a very high level here. So please, if you want to dive into each one of these, I'm very happy to do so. But I'll pause here and really want to hear your thoughts about this set of focused recommendations for the 2024 cost trends report.
David, I think these are a great set of recommendations, and I think they're timely given what we've gone through in the last year. One question for me is, we were ahead of the curve in terms of a state trying to look at, access, cost, quality. Do we know, if I went through this list, do we know where other states are now? I mean, are we, I don't get the feeling that we're at the forefront here. And I'm just curious, I know you spent a lot of time looking at what other states are proposing. Where do we stand?
It's a great question, Commissioner. I think as I look through this list, I can think of at least a few states on each one of these that have gone further than Massachusetts. So I think it is a fair assessment to say that we are no longer a leader in many of these topics. Secretary Walsh?
Yeah, I don't know, David. I would disagree. I mean, I was at that same conference you were. It was standing room only. And most states were saying, that, I think people have elements of it, but not the whole part. I mean, like they might be stronger on physician practices, like I think of California in that way. But I actually think my read, I mean, it was an N of 1 of a conference, but the people were looking to how Massachusetts is doing this, even in light of the Steward challenges, which other states were dealing with as well. So I think we're kind of ahead. I think one of the things I wonder about is verbs like strengthen, like from what to what, or revitalize, help from what to what. Like I wonder if we could, as we talk about this, particularly as we go into the hearings, have a little bit, this would look like this, or we would handle this in a different way. I don't, maybe we have to wait to see what the legislature authorizes us to do, but I think we should have a point of view about what we want them to say, or maybe we're not supposed to. I don't know. You guys can help me with that, but there's something about giving more, like almost like a rheostat to some of the verbs, like, is it all the way up? Is it, are we dimming the lights? Are we, I don't know. Probably I'm out of metaphors, so I'll stop. But
no, thank you, Madam Secretary. And I think your first comment is a fair one. I think I was thinking individually of each of these provisions. I could think of one state that's gone further and another state that's gone further. And so I think your comment on a global point is well made. Maybe let's move to the next slide, actually. So in the recommendations, I think we do get into much more specificity about what we mean by some of these specific words and topics. And so, for example, under strengthen and expand the material change notice process, here we're really talking about expanding the types of transactions that would be noticed to the Health Policy Commission and be subject to our preliminary review and potential cost and market impact review process. There are certain types of transactions that today do not fall within that particular category. And some of these are connected to private equity. So for example, many of the transactions today that do get noticed to us are between a provider and another provider. But if it was a transaction between a provider and a private equity and investment firm, that may not be noticed to us under our current laws and regulations. We see that as an opportunity for changing the statute to make clear that that would be something that is an important transaction to be transparent about, to be noticed, and to be reviewed in the same course of transactions, other transactions that are being reviewed. We also have an example in this recommendation around the significant sale of assets. That would be a transaction, a type of transaction that there should be public notice of and review. Think of the case of Steward. If we had that notice, even a public notice of when they sold their real estate, just to have that information out into the public sphere, that alone, just to have that transparency, would have, I think, been helpful to the public dialogue. So here, our Massachusetts providers, our Massachusetts hospitals, they are complying with the MCN process very diligently. It is really around other types of entities outside of our Massachusetts providers that are not. And how do we make sure that they are also being subject to the same types of transparency and accountability, and really creating a more even playing field that everyone is playing by the same set of rules. So these are the types of examples where we are pretty specific in our language about what types of changes we're looking for. Commissioner Foley?
Yeah, thank you, David. One of the questions I had, particularly about who has to disclose or register with the RPO program, and the recommendation to expand who would get pulled into that review, which I think is a good suggestion, particularly those types of healthcare services that we're seeing go more and more to a for-profit model. Would that recommendation cover home care? I think we've talked about this a number of times and have shown the growth where private equity is making more and more investments, is focused a lot on the home healthcare space. And so I just want to make sure that as we're having that conversation, I saw in the recommendations that we talk about long-term care facilities, behavioral health, all that, which makes a lot of sense. I just don't want to lose focus on home care. And I just want to also just plug the Governor Healy recently just signed the long-term care reform bill that added a lot of new oversight and regulations around disclosure for long-term care nursing home ownerships, particularly if you own 10%, you have to be disclosed for DON purposes and for license purposes as well, to know who all the different owners and investors are in nursing homes. I think that was a really important reform that could inform some of the recommendations we would make in other spaces. So would you consider home care in that space for the RPO?
Absolutely. The change that we're looking for in statute there is actually a pretty small change. It's really around just changing a certain financial threshold. The decision about what types of providers and classes of providers that we would want to pull in would be something that the commission would probably determine through a regulatory process. So that would be our decision as a commission to make. And we may want to, appropriately think about sequencing that and bringing in certain sectors, over time. But it would absolutely not foreclose us from bringing in home care. And if that was a priority, absolutely.
Thank you.
The examples there are really just examples in the text.
Got it. Thanks.
Any other questions or thoughts on the policy recommendations, on these policy recommendations?
maybe let's just, we can just show the next level down of detail on these slides. So here's the next slide that speaks to a little bit more of the detail on the health planning recommendation. Here our recommendation, really is around an opportunity to do more focused assessments of either specific service lines or in specific geographies. And I think Secretary Walsh, I think this recommendation is actually very well aligned with the work that your administration is doing right now in the Neshoba area, in Dorchester, thinking about how we look at a geography and say, what types of services do we need in this area? How do we do this in a way that's data driven? How do we do this in a way that is thinking about patient need? And so this recommendation really is about how do we continue to invest in that type of capability and really expand that to enable the Commonwealth to continue to be proactive in its planning around where do we need services? How can we support that? What are the financial supports we need so that we're not reacting, necessarily to closures, but being able to kind of say, this is what we want in our system. How do we make this viable and sustainable? So I think this is really about supporting some of the work that you're doing. Let's go to the next slide. And here on this final slide, these are recommendations that the HPC has made before. I would note on the first one around inequities and provider pricing. Sometimes we've called this unwarranted price variation. This continues to be an area that we have made recommendations in the past. This is an area that the legislature, continues to wrestle with in terms of policy proposals. Here, we do not have a specific policy recommendation about how necessarily to do this, but we would be, of course, available to the legislature to think through the exact mechanics of how best to do this. Next slide. So we hope that these set of recommendations, provides a blueprint for the legislature and policymakers to be able to take action in a focused way on these necessary market reforms. As I said at the beginning, this is not, the limit of what we think needs to happen. We have a number of other reforms that we've made recommendations on. I will specifically call out a growing concern around pharmacy spending trends that we see in the data. Pharmacy spending trends have been one of the greatest drivers of healthcare spending in recent years in Massachusetts. Given what we've seen with the uptake of some of these new blockbuster drugs, as well as the entry of very high cost new drug therapies, gene therapies, I think we can expect to see that trend will continue. So I do think that is one other area that I would highlight as a particularly high priority, beyond this list for action. And I would also highlight that as a sector in an area that is opaque and is not underneath the same policy and accountability framework as the rest of the healthcare system. And so I think another opportunity to create a level and playing field. So I just wanted to mention that, and we do mention that in the text of our recommendations as well. So I will stop there. Chair DeVoe, happy to answer any more questions, but here is the motion to release our report.
Excellent, thank you. Any other questions or comments before we move to a vote? Commissioner Kwasnick?
Thanks. Took me longer to get to my mute button than I thought. Just wanted to express a lot of thanks to HPC and their staff on all their hard work on this. And it's clearly a very thoughtful document. So just wanted to make sure that we reflected the appreciation that I'm sure we all have for them and their work.
Thank you.
Thank you.
You're here. You're here. Is there other comments or questions before we move to the vote? If not, then can I ask you, Colleen Elstemar, to take us through the vote?
Absolutely. Do I have a motion on the 2024 healthcare cost trends report?
Motion.
And a
Second.
second. Thank you. All right, Chair DeVoe, starting with you.
Aye.
Vice Chair Cohen,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Cutler,
Aye.
Commissioner Foley,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner McGregor,
Aye.
Commissioner Kwasnick,
Aye.
and Secretary Walsh.
Aye.
Thank you.
Great, thanks so much. And we'll look forward to now releasing the report and to the cost trends hearings in November. So now we will move to our next topic, which is a new HPC short on severe maternal morbidity. And can I turn it over to you, David, to introduce the topic?
Yes, absolutely. Yes, so we are now going to turn to a policy area that the HPC has been continuously engaged in both our research and our partnering levers, and that is maternal health. Our most recent research on maternal health uncovered far-ranging inequities in severe maternal morbidity in Massachusetts, and this research was spearheaded by HPC Senior Research Associate Alicia Duran. And I would love to turn it over to Alicia to talk more about this work and to introduce our new HPC short.
Great, thank you, David. Good afternoon, commissioners. Earlier this year, we released a novel study uncovering further inequities in rates of severe maternal morbidity by race and ethnicity, as well as the spending and affordability implications of these adverse health outcomes. Racial and ethnic disparities in severe maternal morbidity, also known as SMM, are well documented, but there's been less research on spending and affordability challenges for birthing people experiencing these dangerous outcomes. In particular, the HPC found that Black non-Hispanic birthing people had a rate of SMM 2.5 times higher than white non-Hispanic birthing people. They also experienced differences in spending and cost sharing. So given the serious implications of this growing issue in the Commonwealth, and in light of the HPC's newest investment program, the HPC's findings are now available as the latest installment in our HPC Shorts video series. Our findings underscore the need for increased investment and policy action to address these inequities in adverse health outcomes for birthing people. The video is now available on the HPC's website and on the YouTube channel, and I'm thrilled to premiere it with you now. I'm happy to take any questions after the video.
Severe maternal morbidity, or SMM, is characterized by unexpected adverse outcomes of labor and delivery for a person giving birth. SMM encompasses 16 life-threatening conditions, such as eclampsia, renal failure, and sepsis, and 5 life-saving procedures, including hysterectomy and ventilation. Some preventable cases of SMM have underlying causes, like high blood pressure, that can be identified for intervention early on, but if left untreated, they can evolve into cases of severe morbidity or even death. For birthing people in Massachusetts, severe maternal morbidity far outnumbers maternal deaths, with fewer than 10 pregnancy-related deaths per year compared to over 800 episodes of severe morbidity. In fact, Massachusetts has among the highest rates of severe maternal morbidity in the U.S., despite performing well on all other measures of reproductive care and women's health. It's well documented that people of color are much more likely to experience severe maternal morbidity. To better understand how racial and
the only one
ethnic
who's not seeing
disparities
this? Am I
contribute to the
frozen?
problem of SMM in Massachusetts,
No,
the
you
Health
are
Policy
not the only
Commission
one not
identified
seeing
labor
this.
and delivery stays
You guys are
and
really
postpartum
patient.
hospitalizations with
Yeah, I'm seeing people trying to queue it up. Should we go on to the next agenda item and come back to this once we can?
Just give us 1 second.
Oh, sure.
Yes, it played for some folks and not for others. That was the confusion there. I think
Oh,
some folks
okay.
were watching it. If you switch to the screen view at the top of the screen, it says Ellie Mador, and you click on her face, then you can see the video. So if we can just, Ellie, if we can just go ahead and hit play on that. We're all gonna watch it together now. Apologies.
Severe maternal morbidity, or SMM, is characterized by unexpected adverse outcomes of labor and delivery for a person giving birth. SMM encompasses 16 life-threatening conditions, such as eclampsia, renal failure, and sepsis, and 5 life-saving procedures, including hysterectomy and ventilation. Some preventable cases of SMM have underlying causes, like high blood pressure, that can be identified for intervention early on, but if left untreated, they can evolve into cases of severe morbidity or even death. For birthing people in Massachusetts, severe maternal morbidity far outnumbers maternal deaths, with fewer than 10 pregnancy-related deaths per year compared to over 800 episodes of severe morbidity. In fact, Massachusetts has among the highest rates of severe maternal morbidity in the U.S., despite performing well on all other measures of reproductive care in women's health. It's well documented that people of color are much more likely to experience severe maternal morbidity. To better understand how racial and ethnic disparities contribute to the problem of SMM in Massachusetts, the Health Policy Commission identified labor and delivery stays and postpartum hospitalizations with
Okay. Thank you so much. Appreciate everyone's patience. Do we have any questions for Alicia? Okay, great. Thank you so much. All right, back to you, Director Seltz.
Thank you. So I'm very proud to segue into our next topic, which is our awardee selection for our latest investment program here at the HPC, which we call our Heart BP program. I'm going to turn this over to Taylor Bungo, who has led this work on our investment team, and we'll be going through the process for our review and selection and our awardee recommendations. And we'll have a vote for consideration of the awardee recommendations at the end of this presentation. I will just note that we are really excited to be able to launch this investment program. It aligns so well with both the research that we've been doing in this particular area, and it has an incredible alignment with the work of the administration, the Healy-Driscoll administration, and the Advancing Health Equity in Massachusetts work in particular. The Advancing Health Equity work in Massachusetts, one of their focus areas has been in maternal health. And so we saw this as an opportunity to really align the work of the HPC with the AHEM work. And as part of our procurement process, we really hoped to have our awardees represent the AHEM communities, which were part of the priority communities as part of the AHEM initiative. And as you'll see, there is a lot of alignment between those. With that as just an exciting preview, I'm happy to turn it over to Taylor, who is zooming in from Florida with us today. Hi, Taylor. I hope you're well.
Yes, thank you, David. We had a power outage last night after evacuating the St. Petersburg area, and then it spontaneously came on this morning. So just in time for the board presentation, we had backup plans in place because we have a great team, but thanks for checking in and excited to be here. So good afternoon, commissioners. Thanks for sticking with us. I'm excited to provide you with an update on our newest investment program. Hypertensive disorders equitably addressed with remote technology for birthing people, or HEART-BP, is a program designed to accelerate the adoption of remote blood pressure monitoring for pregnant people with hypertensive disorders of pregnancy. In this program, awardees will leverage telehealth to facilitate blood pressure monitoring outside of the traditional care setting. The target population for this program is patients with or at risk for hypertensive disorders of pregnancy, which include some of the diagnoses we heard in the short, including chronic hypertension and preeclampsia, among others. The HEART-BP program has been developed, as David referenced, to align with the Commonwealth's priority to improve maternal health and address SMM, and especially among those populations who experience a disproportionate prevalence of hypertensive disorders of pregnancy. Next slide, please. So the HPC will be investing approximately $1.5 million in funding over a 27 to 30-month performance period. This will include a planning period of 3 to 6 months to ensure successful preparation and an evaluation period of 6 months to complete data collection activities. HEART-BP is designed to make awards of up to $300,000 for 4 Distress Hospital Trust Fund eligible hospitals and 1 OB provider through the Payment Reform Trust Fund. So that is totaling 5 awards overall. Next slide, please. The HEART-BP program has 5 aims. The first is to support awardees in making high-quality, patient-centered remote blood pressure monitoring programs available to eligible patients for a minimum of 6 weeks postpartum, covering that period of time post-birth that is really high risk. We also aim to improve access to care, experience of care, and outcomes for birthing folks experiencing hypertensive disorders of pregnancy. Our third aim is to ensure awardees address the presence of or potential for inequities in access, outcomes, and experience in all elements of the program. Fourth, we want to reduce avoidable readmissions and ED visits associated with HDP to support both the clinical and the business case for remote blood pressure monitoring. And finally, we hope that this program collects insights that can inform the development of sustainable and scalable programs across the Commonwealth by collecting data on process, outcomes, experience, and avoided costs. Next slide, please. So in early September, after a competitive process, we received 5 applications for the 5 available awardee slots in the HEART-BP program. And the review and selection committee met for 2 days to carefully review all the applications, and after much deliberation, we're excited to put forth a recommendation to award all 5 applicants. And as you can see here, in addition, we're excited to share excellent alignment between our recommended awardees and the geographic areas of priority for AHEM, or Achieving Health Equity Massachusetts. All 5 applicants who we're recommending for an award today serve at least one, if not several, AHEM priority communities. And these communities reflect areas in the Commonwealth that experience the largest health disparities. On the next several slides, we'll discuss some of the unique features of each of the applicants' proposed programs. Next slide, please. So Berkshire Medical Center, they are proposing to create a new program built on an existing partnership between Berkshire obstetricians, nursing staff, and an external contractor who will provide the technology to implement remote blood pressure monitoring. They also have a plan to leverage these HPC funds for the investments of cost upfront, and then plan to use internal resources to sustain this program beyond the end of the grant period, which is really important in every investment program. A couple of highlights from the program that we're excited about: they have plans to hire a bilingual community health worker to be the patient-facing role. And they also are providing cellular-enabled blood pressure cuffs to ensure equitable access to technology. And finally, they also plan to solicit input from eligible patients to inform the design of their program as well. Next slide, please. Beverly Hospital plans to build on an existing program that they have that is called Beacon. They hope to surface best practices and foster program expansion across the system. So again, a big emphasis on sustaining and scaling this program. We're excited about clinical pharmacists as an interesting role that will serve as the patient's primary point of contact. And they're also doing a lot of thinking around equity with regards to language, ensuring that the tablets that they're using are available in dozens of languages for patients. They also plan to engage with a patient experience advocate to develop appropriately tailored materials to educate patients. And then they have a coordination plan between their existing program and the Heart BP program as well. Next slide, please. Edward M. Kennedy Community Health Center proposes to build on their existing BP monitoring program. And this will include birthing folks both with the diagnosis of hypertensive disorders of pregnancy, but also catching folks proactively who are at risk. They plan to offer a wide range of sizes for remote blood pressure monitoring cuffs to advance equity in that area, and also to create an engagement campaign to really target their outreach to folks that are eligible for this program. And finally, they have plans to have a continuous kind of quality improvement feedback loop throughout so that they can adjust aspects of their program to meet patient demand and provider needs. Next slide, please. Haywood Hospital is planning on creating a new program that involves a bunch of different provider types and an external consultant to provide telehealth technical assistance, as well as the technology to execute this program. They have a maternal care hub that brings together various stakeholders that have a involvement in this area to improve community linkages and strengthen social supports for patients. They also are planning to provide referrals from this program to doula services, which is great to provide additional supports throughout the perinatal experience. And finally, they're also thinking carefully about culturally and linguistically appropriate educational materials so that all patients have equitable access to implementing this type of program. Next slide, please. Next slide, please. There we go. So here you'll see an overview of the next steps for Heart BP, and in a few moments, I'll ask for any questions and a subsequent board vote to approve the 5 recommended awardees. Pending board approval, our program team will begin the contracting process with awardees through the end of the year. And during this time, we'll also be finalizing our plans for technical assistance, which is an important component of our program. That'll provide opportunities for awardees, including foundational anti-racism training and ongoing quality improvement assistance to make adjustments to the program in response to patient needs. January will kick off the beginning of our preparation period to support awardees in standing up their programs, with an anticipated launch for implementation around July. And as we move forward with Heart BP, I'm sure we'll be back in front of you all to discuss our plans for evaluation as well, which is a really critical component, and our plans for learning and dissemination from the insights generated by Heart BP and the awardees. Next slide, please. So I appreciate your time and attention. Happy to take any questions before the vote. Thank you very much.
2 questions, Taylor. One, will the awardees have an opportunity to share experiences with each other?
Yes, absolutely. We have been generating some ideas around kind of convening opportunities. One that we have in motion already actually is we worked with, as you may recall, Pinquin in designing this program. They had 2 kind of pilot sites that implemented similar remote blood pressure monitoring programs, and they've offered to have a convening right off the top with all 5 of our awardees and provide their own insights about what they learned from going through their pilot. And I'm sure that'll be kind of a good kickoff opportunity, and we'll continue to bring folks together so that they can share learnings. And you had a second question, I think, as well.
Yeah, thank you. The second question is, do payers reimburse for this now?
Yeah, great question. So we, as part of the design process, connected with Mass Health, and they were thinking about reimbursement for remote blood pressure monitoring. And they were very supportive of our launch of the program as well. And in August, they did begin reimbursement for remote blood pressure monitoring, including cuffs and education and some patient engagement. So we will be certain to, during our contracting process, communicate with the awardees about encouraging reimbursement through Mass Health for the patients that are eligible. But Heart BP program is open to all patients. And so they will also seek reimbursement, through the HPC for patients that aren't part of Mass Health's reimbursement. There's a kind of a mixed bag of reimbursement outside of Mass Health, and I know that the administration is interested in working with payers to advance insurance coverage, and we're excited to hopefully learn some things from this program to help further that argument. So that's the current status.
Great, thanks so much. Commissioner Blakeney?
Thank you, and Taylor, congratulations on the design of the program and the 5 participants. My question is, could you share yet your thinking about how it is that these programs will be evaluated?
Yes, so it's early stages of that process, but I will say, we have an ambitious, I think, set of variables that we're looking at. One, we want to make sure that we're evaluating, what are the best practices around remote blood pressure monitoring. There's some consensus in the literature around some elements, and there are some instances where we don't really have certainty. There isn't really an evidence base. And so I think one of our evaluation questions will be around kind of what works. How early to enroll folks, how long to stay with them, what do patients need in the process, how do you educate patients and providers? I think that'll be a big component. The other component, I think, will be just some feasibility around implementation so that we can support scaling similar programs across the Commonwealth. And also, I think, looking at cost savings on the back end. Are there readmissions and ED visits that are potentially avoided due to catching some of these issues earlier? through remote blood pressure monitoring. We'll certainly want to share that with the AHIM group. We'll certainly want to share that with payers, and really kind of looking at all of those aspects to see kind of what works. And I guess the final thing I'll say is, because there are inequitable outcomes in SMM right now, it's going to be really essential to see how does racial and ethnic inequities play into this work. What are we hearing from patients through their patient experience? And what can we share about how to combat, one of the underlying drivers of poor outcomes, which is racism at different levels, along with some of the logistical and practical components of implementing remote blood pressure monitoring.
That's great, Taylor. Thank you so much.
Thank you.
Hi, Taylor.
Hi.
Thanks very much for your presentation.
Sure.
And glad to hear that you and your family are safe.
Thank you.
My family is down in Tampa also, and they're safe, thankfully.
Okay, good. Good.
Yes, so just to add to the questions that have already been asked, another question on evaluation with equity in mind as well. So I think monitoring a patient's blood pressure or patient monitoring their own blood pressures is very important to, for example, know when conditions like preeclampsia might be developing, at which point a patient would have to or would be recommended to deliver early in many cases. I guess I wonder how exactly these 5 hospitals intend to really, another question around coordination, to really coordinate with primary care providers and the patient. So for instance, one of my sisters experienced a very severe complication, certainly a case of severe maternal morbidity. She was hospitalized for a very long time after that. She had pre-existing hypertension, and that was something that was known to her providers. But nevertheless, when she was showing signs of severe preeclampsia around 38 or 39 weeks, she couldn't get her providers to sort of listen to her and take her seriously that she needed an emergency C-section. And so I guess I wonder, you said that there'll be some anti-racism training that will be provided. I guess I wonder to what extent these awardees have sort of communicated a plan for either the physicians or the midwives that'll be attending their delivery, to coordinate with the patient themselves around their blood pressure and any blood pressure spikes. How much of that detail is in these applications?
Thank you for that question, Commissioner, and want to acknowledge, I'm sorry that your sister went through that. The applicants provided quite a bit of detail around each of their programs, and obviously the 5 awardees that you see have variability in the types of patient demographics. And at the same time, we understand that regardless of what your community looks like, there are issues, especially with Black and Hispanic folks, of patients not feeling listened to. And that is something that we are really honed in on, I think, as a program team for this work. Remote blood pressure monitoring in and of itself can do a lot of good, and it is insufficient alone to address the SMM crisis. And so we are working with technical assistance providers who have expertise in this area to ensure that that is at the forefront, listening to patients, and being responsive to patients when they say that they need something or something doesn't feel right is going to be a critical component. I think we're going to build a robust patient experience angle to this evaluation work in order to ensure that that is a prominent outcome. I think we also required, as part of the application process, awardees to document how are they going to get insights from eligible patients before they implement the program to help inform how they design it, whether that's educational materials, whether that's quality improvement practices of opportunities to hear from patients during their tenure in the program and have that feedback loop to inform providers about how they're interacting with patients in their communities. So every program is required to have some of that insight and input directly from the patient experience and the patient communities. The other piece that I think is a big emphasis of this program is quality improvement. And the focus of that is, are we looking at the data throughout the program to ensure that every eligible patient is getting enrolled, that patients that are retaining engagement in the program are not just reflective of a certain demographic of patients, and that we're using that feedback again to make every point of the process as equitable as possible and respond to the very real issues that patients have voiced about not being heard and understood.
Absolutely, because that is critically important because, every additional delay for a patient that's showing these symptoms can really mean life or death. So glad to hear that that's a part of the program. And then, if I may, I just wanted to emphasize one of the findings from the severe maternal morbidity research that the Health Policy Commission team conducted. So again, congratulations, Alicia and team on that work. And sorry about the technical difficulty today. But to highlight one important finding there that folks can check out on their own time, this finding was particularly disturbing because not only do Black birthing people experience the brunt of severe maternal morbidity, but they also bear more of the costs. So they faced higher costs and higher out-of-pocket costs in particular. So an intervention like this, which is relatively cheap, all things considered, I think we definitely ought to continue investing in these types of interventions to reduce inequities there. So thank you very much.
Absolutely, thank you.
Yeah, good point. And to the extent we can use the findings on what we learned from this to encourage payers to consider it as an intervention, a paid reimbursed intervention, I think could be a plus in that.
Absolutely.
Other questions or comments for Taylor? Well, as you can see, there's tremendous interest in what's ahead. So we'll look forward, as you promised, to seeing how things go.
Yes.
And any final comments from you, Taylor?
No, I appreciate the board support and the administration support, and I'm really looking forward to the impact that this program will have. And thank you to my team who set me up for success today amidst all of the hurricane chaos.
Great, thank you.
Thank you.
So we'll now turn to the motion ahead of us to vote to approve the selection of awardees as described. And Colleen, can I turn it over to you to walk us through the vote?
Absolutely, you can. Is there a motion to approve the recommendations?
So moved.
And a second?
Okay.
Okay, starting with you, Chair DeVoe.
Approved.
Vice Chair Cohen.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Master Giovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Kwasnick,
Aye.
and Secretary Walsh.
Aye.
Thank you. Okay, back to you, Madam Chair, to close us out.
Great. Well, we've accomplished a lot today. Any final questions or comments, or Director Seltz, any closing remarks before we adjourn?
Just one last note on the last agenda item. I did want to recognize Dr. McGregor and her guidance and expertise in the research work that we did on the serious maternal morbidity work and that research. And she's been such an incredible thought partner on that. So I wanted to thank her for that.
Thank you so much, David. It's a pleasure, but I think the credit goes to the team.
Thank you. That's great. Well, I want to thank you all for an incredibly productive and positive meeting. We'll look forward to cost trends in November. And did we want to review anything else before we close? Do we want to? Yeah, great. So, yeah, we've got cost trends on November 14th, and then we're showing our next board and committee meetings.
That's right. Two more meetings before the end of the year after the cost trends hearing in December. So we'll see you all soon.
Great. Terrific. And with that, we'll adjourn our formal session. Thank you all.
Thank you.
Thank you.
Thank you. Have a good day.